So, yeah, Dr. Dryman, as I mentioned, she went to medical school with me. So we both went to Lake Erie College of Osteopathic Medicine over in the Bradenton campus. So she's doing her general surgery residency, where she's now a fourth year resident, almost done. Congratulations on that, at University of Pittsburgh Medical Center. And her main areas of interest are cardiothoracic surgery. And so I'll let Dr. Drymon take it from here, and we'll go ahead and get started. Again, thank you all so much for staying on the line for us.
All right. Well, thank you so much for having me. I'm very excited to be here. I'm glad that I can contribute in some way. This is kind of new for me, so I'm happy to provide any kind of information that I can. So like Gabby said, yes, I did go to school down in Florida. I'm actually born and raised in Sarasota, so right outside where we went to school. I stayed local there, and then I moved up here to Pittsburgh to complete my residency. Currently fourth year out of 5, so I have one more year to go after this. I am applying for fellowship this year. We'll see how that goes. Cardiothoracic fellowship is 2 years long, so it would be an additional 2 years of training. And we'll just see how that process goes here. It starts within the next month as far as applications go. So yeah, as far as being underrepresented, it's been an interesting journey for me as far as throughout medical school and throughout residency so far. I would say medical school was less so. I had such a great support group of friends. Gabby was my next door neighbor for a long time. And I loved having her right next door, actually. And we just kind of, I was at that time living my life as a gay man, which I had lived as a gay man since I was maybe 18. Was when I had come out to my family. Before then, I really just didn't have a whole lot of experience with kind of self-identity and figuring out what I was doing. I was more focused on school and activities. So I never really delved into who I was as a person. But at that time, I kind of accepted myself. My family was fantastic. They accepted me. And that was when I started living as a gay man. And then I recently just transitioned as a trans woman, actually in residency, which has been a challenge in certain ways. It has been a journey that has required a lot of patience and understanding, and it's very different from being gay in modern society, I would say. I would say it's almost less well accepted and known, and it makes people maybe a little bit more uncomfortable. At least these are the things I've encountered thus far in my field. And it is something that a lot of people need a little bit more education about. As far as being able to communicate with your patients, communicate with your fellow providers, etc. So I have been living publicly and professionally as a woman only since April of this year. So it's been relatively recent that I have come out as female to my peers. It has been a journey, and still is a journey for them, just as it is for me. I lived as a female for a short period of time prior to that. Gabby was actually one of my first people that I reached out to kind of just for support, just because it's difficult, not only, being underrepresented in medicine, but just in general. So having someone that you can relate to who has kind of done this with finesse to an extent, and you can follow and take advice from is really important, especially with certain aspects of not only life on a personal scale, but on a professional scale. So yeah, that's kind of my journey to this point. We're still learning together, my peers and I. I was the first gay resident at my training site, and I'm now the first transgender resident. It is a very new concept to everyone around me. Thankfully, they're all very understanding. I haven't had any, negative interactions thus far with any of my fellow providers, which is fantastic. It's just been um, a learning experience for sure. And not only um, it's been difficult to kind of meld how you live your personal life and express yourself in a professional manner as well. I think that's something that's tricky. Um, Waking up and seeing yourself as the same provider to your patients is difficult sometimes when you don't exactly necessarily look in the mirror and um, relate to what you see. It can be hard to provide what the level of care that you feel you want to provide to your patients. So um, there's a whole different slew of challenges that not only transgender individuals face in medicine, but also just any underrepresented minority, LGBTQ, especially individuals within our field. They not, I wouldn't say struggle necessarily, but they can, and they face certain challenges that they maybe should not have to, and hopefully one day will not have to. Um, but for now, I think awareness and education is important, which is why we do things like this. So, yeah, I don't know how much more I have to add. I don't have a whole lot of excitement going on at the moment. So,
It's okay, Dr. Dryman. Thank you for providing a little bit of your perspective. In terms of being underrepresented, is there any instances that you dealt with patients that either microaggressions or anything like that that you either had to deal with in the moment or discuss with like your program leadership or anyone that you can confide in?
sure, sure. So there are definitely microaggressions from patients, like you say. Thankfully, nothing outward that has been a significant challenge. But from a patient perspective, there's a lot of things as you begin your transition that are kind of tricky for some people more so than others. One of mine is my voice. My voice tends to be rather low. I'm tall and I've always had a lower voice. So, waking my patients up at 4 a.m. on rounds in a dark room, they tend to be disoriented. And when there's this towering figure with this low voice, yes, sir tends to come to mind naturally for them, which can make conversations awkward and difficult sometimes. Um, I don't know that I would consider that a microaggression because it's not necessarily done on purpose on their fault, but it can be something that can make you uncomfortable as a provider if you don't feel like you're connecting with your patients appropriately. So that's something that has been a continued source of frustration for sure. Initially, legalization of of your transition while you're training and being an active a provider to people is difficult. Um, I know, Gabby, you transitioned during medical school, and I don't know like the process that happened, that occurred, and I know that with the name, with you changing your name and having to present yourself differently, is such a challenge. Um, Thankfully, my name is rather androgynous, so I just kept Alex, which made things a lot easier for people. However, my name badge, for example, during residency had my picture from medical school with my full beard and Alexander written across the top. And so when patients would see me coming in presenting as a female and not necessarily relating to that badge, that kind of discord is difficult to explain, especially to older populations or underserved populations who may not be familiar with transgender healthcare or transgender people in general. There's plenty of older individuals who have not been taken care of or even seen or related or spoken to a transgender individual. And there are times when it is obvious early in your transition to the patient that something is a little bit different about your provider, and maybe that makes them uncomfortable. So the legalization, what I'm trying to boil down to is the legalization of things while you can't take a break, is a challenge in some ways. Also, working, my program is rather small as far as my training program. I'm very close with my residents. They're all basically my family, and my attendings are also basically my family as well. They are all, none of them are underrepresented minorities. None of them had to even interact with a LGBT resident prior to my arrival. So not only was that new to them, but then a few years into my training, coming out as transgender was very difficult for these men who are older in their training. And, surgeons, as some of you may know, have an air about them. They are stuck in their ways and have strong things to say. So, with that being said, they still to this day struggle with pronouns. They still struggle with, being able to present me as one of their fellow providers to their patients. And it's getting better with time. And I believe that if there was ever another LGBT individual to come to our residency program, they would now be so much more prepared based on not even work that I've done, but just my presence and being here. And I think that's what's important, is having a presence, making your presence known, being able to communicate with people, even when it's uncomfortable, being vulnerable with people, being able to express yourself so that they understand and feel comfortable talking to you about things. There's been a lot of uncomfortable conversations that were put off because they felt that I may be offended, or that I may be, I may close a form of conversation with them in ways that would, harm our professional and our personal interrelational skills. With that being said, that's just a challenge in general. Things like having longer nails, simple things, having longer nails, or having longer hair, or dressing a certain way for conferences and education and grand rounds. There have been times where attendings have questioned me and say, like, should you be wearing that? Should you be presenting like that? And they don't mean it in a harmful way. They're just curious. And that they need to be educated. They need to be told, this is okay. This is a professional way to present myself. And it's okay that you asked. It's okay that we kind of figure this out together. And we will still go to the operating room. And when I have all of my mask and everything on, you can call me whatever you want, whatever feels comfortable to you. And that's kind of how we get along. And that breaking down those barriers have been so healthy, not only for my relationship with my co-residents and my attendings, but also for their interrelations. I can see how they are now more comfortable in certain ways talking about normally maybe taboo or difficult topics, politically, interprofessionally, talking about other providers, other patients, how they relate to patients. Especially LGBT patients, we see them now. They're better equipped to be able to handle this. So again, I'm not doing anything special here. I'm just trying to live my life as a surgical resident, which is difficult. But I'm thankful for the position of being able to provide something for those around me, because I know my service and my group provides such an important service to our community, and it just makes us that much stronger, I think, in that sense. And I think anyone who is maybe in a similar boat and is concerned should maybe take the perspective of, you are here to train them. You have the ability to train others in a way that maybe someone else has not had yet. You have the chance to change how other people view the world around them, can be more comfortable with the people around them, and kind of break down those barriers. I think these are all important things that all of us can make a simple effort. It is uncomfortable, and it's okay that it's uncomfortable, and that strength is important. My 2 cents.
Thank you so much. Your 2 cents are always well appreciated. You're getting a lot of love here in the chat, and living your truth is a very powerful thing. And you foreshadowed a little bit about my talk tomorrow, so I know a little bit about your personal experience as well. So if anyone's here, they can do that. Listen tomorrow morning about my perspective. But I had a question also in terms of, we're in different specialties. So general surgery for some can be considered a quote unquote boys club. Just from the demographics that we see from the data. And I'm just kind of curious, how is that navigating maybe more male predominant fields? And, maybe you see more microaggressions just from a sexism component, not necessarily just from gender identity.
100%. So, I would love to say everything is PC, but it's not. Especially in the field of surgery. It is a boys club. I am one of 2 current female residents in our program, which is like a, big hurrah for us at this point. It's difficult for you to kind of present yourself not only as an underrepresented person, but as a female in certain fields. Surgery is one of them. There are ways that you can go about that dynamic, and really show that the care that you're providing is different, but not only comparable, but in some ways more so beneficial. There's been a whole lot of data in recent studies that show that female surgeons tend to provide better care based on patient perspective than a male surgeon. I think it's just kind of that feminine touch in general. That's no offense to any male surgeons, of course. That's the predominance of the surgical community at this point. But there is a degree of looking down. There's still a degree of disparity. There's a degree of differences in pay, just like you would see in any field. Maybe a little bit more exaggerated in mine than others. But it really boils down to, as an individual, staking your claim. These are concepts that I pray that no one ever really has to do, but if they have the opportunity to do, they should, no matter what specialty they're in, with their providers or their fellow people that they interact with, their staff, their physicians from other fields, anyone that you interact with as a professional. It should be very clear who you are, what you are providing to people, and what is and is not acceptable. As a female, I see countless times those around me getting abused, not physically, of course, but mentally and emotionally by other male providers. And I can tell that dynamic is different. Female surgeons tend to in a way, I would say overcompensate for this by being a little bit snarkier. If anyone has any experience, they would probably know what I'm talking about. Female surgeons tend to have a worse reputation than males. I think for this sense, because they have had to suffer this disparity, which is so unfortunate, but it's just reality. It's the tradition of this field, and it is changing. I can tell that it is changing. Um, there are female physicians coming in who are really paving the way for this field, and I know in other fields as well. And it's critical. It's critical. And our niche as transgender females is also especially critical at this time. You know.
Thank you. And as you know, your medical training has progressed, you're already a fourth year surgery resident. How would you say, maybe your transition has impacted your clinical care in positive ways or negative ways? Do you feel like you become more proficient as a surgeon as you've been living your truth?
Um, yeah, that's an interesting question, and it's something that I've tried to reflect on, um, and see, how has my personal growth affected the care that I've provided. When I'm in an operating room and I'm working, um, it's kind of like a block out. Um, I'm not even Alex, I'm who I am. And we're all yelling and screaming and having a good time and working. And there's a special environment that is an operating room that most probably don't appreciate, but those that are in the field appreciate that dynamic. And I don't believe that that has changed. As far as my technical proficiency, my ability to work, because in the OR, it's straight business. However, the OR is such a small part of what I provide as a surgical resident. Um, Most of the care that I provide is done on the floor, in the clinic, um, doing procedures, uh, interacting with people when they're awake that are strangers, that are not my team. And I never believed that I truly put on a facade as a male. This is, of course, all rapidly evolving. I am still very new in my transition, and things um, develop as I learn more about myself. Um, my coming out as a transgender female was not something that was um, held back by myself for a long time. It wasn't buried down. Um, I truly lived my life as a gay male um, truthfully. And then as I delved further into my mental health, realized that I was a transgender female. And when I came to that realization, thankfully for myself, I have the kind of blunt personality of saying this is what needs to be done for me to live. Period. So when I changed that, I could tell that my care that I was providing changed as well. There are things that influence that. Hormones, big one. You know, being comfortable in your skin, even bigger. Um, Being able to talk to someone knowing that you are presenting a feminine energy that is true, that is your reality. Maybe I'm not necessarily the most feminine person, but accepting who you are as a female and being able to use that in your communication with a person has absolutely changed how I have interacted with my patients. And therefore, I believe, at least, from their perspective, they feel like they are receiving better care because they are seeing someone who is coming to them, sitting down in that chair next to their bed, having a truthful conversation, person to person. That wall of discomfort that maybe many residents face, where when they're rounding, they're walking into a room, they're standing in the corner, they're kind of spouting information to a patient and they leave. I see it every day. And I teach my younger residents that that's not how I want them to learn to provide care. It's person to person. Um, we are in this special position of quote unquote power with being able to take care of people when they need help. Being able to break down that barrier and sit with them as an individual that struggles just like they do. It may be in different ways, of course, and they aren't post-op and hurting and all this right now, but you know that relatability um, is something that I have developed as I've transitioned and I'm continuing to develop. And it's something that I'm really proud of as far as the care that I provide. Yeah.
Fantastic. And we know that just in general, there are some healthcare disparities amongst LGBTQ patients. You don't, if you feel comfortable, you can, if there's been any instances that you've experienced, or if not, how that affects, how your LGBTQ patients interact in the hospital. Like, do they feel more comfortable knowing that there's an LGBTQ provider giving them their care today?
Yes. So this happens, and it's very real. It's something that, um, in general, like I said, when a patient is seen by us, they're scared. They're most of the time scared because they are in a position of vulnerability. So not only do patients across the board have this position of vulnerability, LGBT individuals have a baseline vulnerability that is most of the time severe. They can struggle with basic communication. They can struggle with being able to voice their needs, and things can be missed that can be detrimental. Um, I make a very clear point that if there is an LGBT patient that needs to be seen or evaluated by our service, that is my patient. Um, the reason being, having that connection is not only about this community that I love to have with people in general in the LGBTQ field, but because I know that I'm going to be able to break down barriers that my co-providers are not going to be able to. That's not because they are not proficient or understanding. That is because relatability is a basic human need. This is something that um, I've been asked to see patients who are. I've been asked multiple times to see patients who are psych patients struggling in our emergency department. And is that completely within my scope as a surgical resident? No, but the care that I have been able to provide simply by communicating with them, maybe acting as a liaison between their provider that doesn't quite understand them and their needs, being able to be that person and that middleman or middlewoman, whoever you want to be, is critical. Because people will not get their needs met. People will attempt to blow things over and avoid confrontation and get to a breaking point, which is so sad to see. So thankfully, those issues, I know in the field of psychiatry, I can't imagine, Gabby, the things that you face dealing with these patients as far as them reaching their breaking point in areas like this. such a commendable thing to be able to grapple with that. I thankfully, am really just in a position where I can relate to someone a little bit better, and in that sense, provide them better care as a quote unquote technician in addition to a physician. Um, I don't know that I would even truly be able to delve into the complexity of transgender individuals at this time based on my where I am in my personal journey. But no matter where anyone is in their personal journey, even as a straight white male, anyone can learn, anyone can make an effort, and anyone can connect if you want to. And it's so important to want to, because we're missing things. In my opinion, we're missing things, and sometimes those things are big. So.
Absolutely. And I think just coming to the table and having the conversation is how you reduce some of these stigmas, how you reduce some of these inequalities, and how that's kind of why we do these types of things on the represented populations. Is let's get people at the table and let's talk about it. And kind of in this vein, I did actually get a question in the chat. So this is coming from a person that is an international medical graduate. They're saying that from their background, there just isn't as much education regarding the LGBTQ community. And as they're looking forward to entering residency in the US, they're afraid that they might, come off the wrong way or commit, microaggression, just from more of a lack of knowledge, so to say. So from your perspective, can you shed some light a little bit on what colleagues can do to extend or improve their support? And then if you've seen anything that you felt could have been improved upon in certain situations as well.
Sure. So, as you know, Gabby, in our training, in medical school in America, even, not only patient relatability and communication, I believe, is lacking in our education, but especially in these underrepresented minorities. Even, I say even, but anywhere where you are trained medically, it is. I don't believe it's getting the credit that is necessary, because that ability to communicate is the foundation. If you don't have that, you're not going to be able to do what you need to do. So I work with plenty of physicians from other countries who struggle with communicating with those of minorities. Language barriers, social barriers, and then especially these, community barriers like the LGBTQ community. And they have come to me and asked for advice, assistance, again, with just kind of being like a liaison in the room. Your concern, I think, speaks volumes. I think that's what's key, is if you have enough mental energy to have a actual true concern, then you're on the right path. It doesn't take, people don't need much. People don't need much as far as being able to be related to. Everyone just wants respect as a person. There's a concern that you could misgender, misappropriate someone, and they would not correct you, and that would create a barrier. This comes to my mind every day. This is something that's common, and that I think hard about. And I could see that being a potential concern. But if you simply have that in the back of your head and are asking, as I'm evaluating this person, or as I am getting ready to interact with this fellow physician to patient, to relative and loved one, or stranger on the street, if you can say, I am okay being humbled by not understanding certain things. I am okay with opening and asking awkward questions, and being in a position of vulnerability myself, so that they can further feel comfortable with their expression. That's what's key. Make yourself the person that they want to talk to, that they want to express themselves to, that they want to share the information that they're not sharing with anyone else. You don't need to be grilling them and asking them questions. It doesn't necessarily need to be as formal as asking pronouns and asking sexual identity. And, sometimes that is required, but sometimes it's just saying, how do you like to be, what do you like to be called? How do you like to be referred to? Is there anything I can get you? Do you need anything that you're not getting right now? Making very light conversation in an attempt to close the gap between patient and provider communication, to where the patient can feel like you're on the same level, seems to be the most successful tool that I have found. Joking around, making very simple, sly conversation. In general, people know me for having a mouth and a personality, and I will run with that as far as with my patients, and they're able to relate to me that way. I had an older patient, for example, who is a regular on the service. Surgical services have our regulars just like everyone else does. And she knew me from the time that I was a male, and she saw, or it presented as a male, and she saw the difference, and she was confused. I could see the confusion, and I could see her working on it. And I work in Western Pennsylvania, where it is not the most progressive or forward-thinking region in the world. Definitely, even in America, this is a more slow, old-timey area with an older population. It's not very diverse here, and so I could watch her as she was. But this woman was a peach, so I could watch her as she's trying to figure this out. And eventually, I just told her, like, Teresa, are you confused? Are you confused? Do I need to verify for you? Because you see my hair, you see me coming in with like my makeup and my nails now. Are you confused? And she's like, yeah, I'm confused. And I was like, okay, well, let's talk about that. Being able to be that person who's just make it, I don't know. That's my strategy, is make it blunt, make it almost funny, make it something to where you're the one, quote unquote, taking the hit. Patients appreciate that. And now whenever she comes to the hospital, she's asking for me. She's asking for the person that she knows is going to communicate with her straight, and not give her any garbage, and is going to talk to her like a person. These are tools not only for us to communicate, but to be better communicators than those around us. This disparity, this discomfort, this a difficult situation is something that we can all use to be better than the other providers at communicating. Take those challenges if you have them, run with them, learn from them. It's okay to make a mistake. If you offend a patient, talk about it, communicate. I apologize. I misunderstood. We're all just people here trying to learn. And if you take that approach, I think you're going to really see the benefit. Don't worry about where you're coming from, language barriers. We're all people. Break the physician-patient barrier and communicate person to person, and you're going to be really shocked about what result you get, in my opinion.
Yeah, absolutely. And I think in any specialty, you can communicating with your patients is really key, and not using medical jargon, but also coming to them from a place of concern. It's like I don't want to leave a room. My patient have no idea what the heck I just said to them, and especially in surgery, there's this particular degree of vulnerability. And you just also told me you're a surgeon without telling me you're a surgeon by telling me about your mouth and your manner, and that. I just, joking aside, I thought that was very interesting. But again, I appreciate from that perspective. I think you mentioned working with physicians from other countries, in your own specialty, and I know we have some others in the group here as well. What are your experiences either with them or just like from residency application and things like that from other folks that are from international medical graduates? Because in some specialties that I think Dr. Mansouri was mentioning this earlier, they can be considered underrepresented in their fields as well. So what are your thoughts in terms of like increasing that type of awareness in your field? And now you're a senior resident, you've been involved in the interviewing of international medical graduates.
Yes. So yeah, this is actually, it's good timing for this conversation. I know that so far I've kind of been discussing, I've been focused on LGBTQ as the underrepresented minority, but international medical graduates coming into our field is also an underrepresented minority that I am now getting to witness firsthand. The hiring and licensing and difficulties that they face as a rising chief this year. I'm now the one running our applications. I weeded through all 1,000 for this cycle for my program. I looked at I looked at where everyone was from, and I saw almost this subconscious need on a piece of paper to compensate as an international medical graduate. Now, my training program is I'm a DO. I graduated from a DO school. It is a traditionally DO training program. It was one of the first general surgery DO training programs in the country. It was opened in 1971. We did not hire an MD resident until I was a second year, and that's my co-resident. Other than that, we have had only DOs. We have only interviewed DOs. It has been almost like a lockout program in the sense that many DOs struggle from that in an MD world as well. We kind of had it in reverse. So with that being said, the way that the ACGME merger and everything has kind of worked out recently, my residency program, based on the voice of my co-residents, my attendings are all wonderful people, but they are set in their ways. They are older gentlemen who are set in their ways. My residents have been fantastic and a great driving force that I have seen from my time as an intern to now, which in a span of 4 years is incredible. We have multiple international medical graduates in my program. We have multiple MDs, an MD PhD. We've had those that have trained in other countries and have come here to retrain. And to say that there is not a disparity there in their application is a lie. There's a struggle from even things like a paperwork perspective, visas and things that I don't understand, to be honest. But then there's also things like feeling that they need to compensate in a certain way, that the training that they receive, that Americans receive, is better, and that they need to compensate with better board scores or compensate with a better interviewer performance or something, when it's really not the case. It's been very clear, at least in my small cohort, that the international medical graduates are just as competent, just as well-trained, uh, appropriately interprofessional, and technically savvy to provide the same care that the American trained physicians have been able to. Now, that being said, we weed through them carefully. Was working through all of them this year, but I don't think in a more progressive thinking program, which I consider my program now, because of the way that my residents have been trained and brought up. Even the younger residents now have been given this new mindset, and it's beautiful to watch. And I'm so excited to go to next year and watch all of my little ducklings, be this like fantastic array, this diverse group. And I'm excited to watch that legacy be left, as I came in as the white male DO, and now I'm of a group of entirely DOs, and leaving this completely different training facility that is so much better. And it's so much better because of our diversity, truly. IMGs, I do not understand the difficulties that you face firsthand, but I can empathize, or whatever the word is that I'm looking for. I can understand your struggle. When you find the correct program that you're supposed to be training in, it's not going to matter. Focus on yourself as an individual and what you have to bring to the table. Do not, in my opinion, these are all my opinions, of course, do not try to sell yourself in a way that you are less than an American trained graduate for any reason, because you're not. You take the same standardized examinations, you have letters of recommendation, and you go through the same application portal that we do. As far as visas, things like that, these are all things that program coordinators take care of. We're looking at you as a physician to see whether or not you are going to meld with our group, to see whether or not you are going to provide good care for our patients and be a reliable resident. Again, at least from my program, I would pray that it was the same universally. I know that it's not. We're trying to get feet in the door here. You got to get people who are making that effort everywhere. I hope one day it will be like that.
Yeah, that's fantastic. Thank you, Dr. Dryman. So yeah, and I think that's very fascinating. So just to provide some context to some of the people here that may not be aware. So up until 2020, there were traditionally allopathic and traditionally osteopathic. So traditionally MD and then traditionally DO residency programs. And traditionally most of DOs are mostly in the United States. So up until recently, Dr. I think you were actually the last group that was in the before they merged. I remember when I was in school, that was a big topic of conversation. So it's just interesting that now some of these traditionally DO programs are opening up, or at least from your, obviously just from the one that you were discussing, but it seems like that's probably going to be the case for others as well. Just surmising that now there's more openings and more opportunities perhaps for other international medical graduates to go into the traditionally DO programs. I'm not sure if you talked to anyone in other general surgery programs that have had the same experience as y'all have had.
I would say it's still a challenge universally. I wish it wasn't. I voice myself as loud as I can. And I know, I work closely with residents at other training sites that are geographically close as well. And some are open and some are not. And it's reality. It's the reality that we face currently. I wish it wasn't. And all I can say is that I'm proud of where my group has developed to and where we are now. And I hope that others will join.
Any recommendations that you would give for any like international medical graduates looking to get their foot into the door into US-based general surgery programs?
Yeah, I think that is um, that's a challenge. That in general is a challenge. Being an IMG and coming to an American surgical training program is a feat in and of itself, um, because you are being vetted against even some of the best American applicants. Um, if you are applying to programs even as progressive as mine, where MD, DO, IMG does not matter, we truly can toss that out. You are still being vetted against the best. And I'm not going to treat you any different than anyone else based on your credentials. Uh, so that being said, what can you do to get your foot in the door? The best thing is going to be not only being strategic with your applications and networking, so that you know where is going to be an open and acceptable training site for you. This networking is hard. You have to talk to someone who knows someone who knows someone. I am always available to anyone who's listening to talk to be able to, because I have had to go through the process of figuring out what programs are more open to this than others. So I'm always happy to share that information. That being said, the biggest thing that you are going to be able to bring to the table is who you are as a person and your personality. When you're given, and this is something that I believe goes for every field, it at least goes for ours, is when you're given an interview, you've met your criteria. We're now judging you as a person. So if we like you versus if we don't like you, and it's that simple. Are we going to get along with you for 5 years? Because if not, then it's not going to work. It's like dating. It's like figuring out if the relationship is going to work. So that is really how it has boiled down to as far as our process goes. I would make sure there's certain things, just like in the dating world, that are tacky and gross. Don't oversell yourself. I don't want to hear about all your credentials. I read them. Trust me, we read them. I want to hear something interesting about you, something that makes me remember you. I remember there's this one interviewee that was like telling me about his sock collection or something. And we were like going off about his sock collection. And it was like, what a weird man. But I remembered him. Even after these years, I remember him because I had something that was unique that we could connect on. Maybe not, maybe not like I'm loving socks the way he is, but there was this unique dynamic. I want to know something unique about you. I want to see what you have to bring here, because the opinion of my trainers is we can train anyone to be a surgeon. I can take anyone and I can put them through the ringer that is a general surgical training program, and they can come out to a degree successful. We have never had a board failure. We have never had anyone who does not get the fellowship that they want. We have always proven ourselves in that way. And we have taken those who have barely passed their boards. We have taken those who have had failures in medical school. We have taken those with what are considered, red flag applications. Like some people would consider an IMG a red flag application. We take anyone, and a confident general surgical and a confident training program in general should say, I can take anyone and I can make them good. What do you have to bring to us? What are you going to do to make this program better? Because that's the game, is it's a two-way street. I want to see you come in as a strong intern. I want to see you blend and work hard and be unique and be yourself. And basic human traits that I think get lost in trying to sell yourself as a board score and a letter of recommendation. Don't do that. We don't care anymore. We don't care. So
Yeah, exactly. So Dr. Jarman really touched on an important point here. And I know in certain spaces it can be difficult getting the foot in the door. But if you do get an interview invitation, on paper, you are good enough to train at that program. It's just a matter of finding a goodness of fit and personality wise. So don't be afraid to be yourself and tell us a little bit of unique things about you. Like, I mean, I don't know if sock gentleman match.
We don't do the socks. So maybe don't do the socks.
I mean, I
We didn't
guess.
stick with them.
Yeah, I guess the surgical scrubs cover the socks, I suppose. So that probably it might have been why. But suffice to say, I just wanted to at least mention that, because I say that to all people that are going through the residency application season, is that if you do get an interview, on paper, you are good enough to match. You don't necessarily have to talk about publications as much or board scores as much. I mean, you can highlight it a little bit, but you don't have to have a big billboard that says, hey, I did this X, Y, or Z. Like they already know that. And it's just more a matter of, are you able to have that goodness of fit from a personality standpoint, especially for y'all. I don't know how y'all do it 5 years, but that's a long time to be in a program. So, I think it's important to have that perspective when it comes from training individuals.
Yeah. And don't forget that it's two ways. This is not just something where you are being given it. I know oftentimes it feels like you're being given a privilege to go anywhere that could potentially take you. I remember feeling that way right before my match. Anywhere that could take me would be a privilege. But this is a two-way street. You have to blend with them. If you're interviewing with people, with a training program, and it's not meshing, there were times where I told them, I am not interested in the heavy research that you guys are doing. I am not interested, and I never told it to their face, but we don't blend, we don't get along. I don't think this is going to work. So don't sell yourself short to where you're searching for a name at a big name facility, where you're searching for anyone that will take you. Make sure that you're getting something that you want, because this is going to be your life for, especially if you're in surgical training, at least 80 hours a week, every week, for a long time. These are people who you're going to be yelling at, fighting with, grabbing at each other's throats, because they're your family. And you're going through hard things together. You're all exhausted. You're all tired. You all don't want to do that next case. You can't believe that there's still 3 more consults. It doesn't matter. You have to do this. You have to be able to work with these people. And it's going to be really interesting as I start my fellowship application, how I'm going to interview and kind of delineate that to them and see what kind of feedback I get. Because I think that's something that I've learned is so critical, is you have to be able to work with your people. You have to be able to work at that facility. Otherwise, you're going to be miserable, even if you love that field, So there's a match for everyone, but sometimes you really got to, it might not be where you think it is. I did not think mine was in Western Pennsylvania until I got here. And it's sometimes just surprising.
Yeah, thank you, Dr. Dryman. I guess we've touched this a little bit before, but just from being a member of the LGBTQ community, I know we talked about just like having open discussions and things like that. What are just kind of like specific things that other people might be able to do to make others feel comfortable, or to be an ally to the community?
Yeah, I think that's important. This is something that I get asked a lot by those who are not part of the LGBT community. Like I said, my trainers, for example, when they decide to open up and ask that uncomfortable question, it breaks down barriers and it allows them to not only learn how to interact with me, but with every potentially every LGBTQ individual that they are going to face in the remainder of their career. Simple questions like offering respect, how do you there's certain questions that I think it's very individualized that you ask someone. um, what are your pronouns is something that I hear a lot, and coming out of my mouth that sounds a little formal. I'm not a formal person. I usually ask, what do you like to be called? um, uh, Figure out how you want to interact with someone that still treats them with the same respect, um, allows you to ask those uncomfortable questions. um, I'm trying to think of like some good examples of of questions that, I've had some really hard ones from people who, especially like I'm like thinking back to April when I came to my attendings and I said, like, hey, this is what's going to be happening. And they're like, what are we gonna do? You are 6'1" with a low voice and this Adam's apple, and you still are looking relatively masculine. What are we going to do when a patient doesn't want to talk to you or doesn't feel comfortable with your care? um, what an awkward, uncomfortable question. And it is reality that you have to be able to face. um, at the time, it was uncomfortable for me to be able to answer as a member of the community. However, it is something that was so real and raw of them to be able to ask that in retrospect, I truly appreciate their um, attempt to look into the future and say, if this worst case scenario happens, what are we supposed to do? How can we support you? Um, which maybe is kind of like the crux of the issue is how are we going to be able to support you um, when the time comes? And hopefully it never comes. Hopefully things are always smooth sailing, but that's not life. So when the time comes, having some kind of a plan, or at least an idea of what we can do is important. And I think that's something as an ally that you can make an effort to at least voice as you get more comfortable with the people that you work with, or live with, or are in your community around you, your neighbors. It extends outside of the professional field, but especially in the professional field, some people are comfortable talking about things, some people are not. Not everyone is as public and an advocate as I'm trying to be um, in my community. And for the people who you offer that attempted support and they decline it, you have to be able to say that's okay. Everyone is at a different phase in their journey in life. Everyone needs different things. And you are, in my opinion, never offending someone by offering them the potential to help if they're struggling. Just lending out a hand and saying, hey, if something is wrong, do you want me to be someone that you can come to talk to? Um, if there is a challenge to where you can't mentally come to work today, do you want me to be a backup for you? Do you want me to be a point of contact for you? Do you want me to be a liaison for you if it's ever needed? Um, you know, can I go to bat for you if it's needed? Having that kind of support is so monumental for individuals of the LGBTQ community. Knowing that they have an ally that they are close with professionally, at home, whatever, that, but especially professionally at work, that if something were to go wrong, that they would have a backup is a beautiful thing. And it's something so simple for allies to do. And I think it's something that allies want to do that maybe they just don't know how to say that they want to do that, you know?
Absolutely. And I think just being supportive in social transition is very important. Other just types of initiatives that we can do just with our patients as well is when you're going over social history, don't just assume that they're partners of the opposite sex, for example, or putting preferred pronouns or preferred names on intake forms and things like that. Those kind of things also help reduce disparities that we see. And both Alex and myself have gone through those instances where we're getting medical care. So those are all types of things that as we move forward, it helps us feel more, comfortable in the medical field, but also just as patients, because every single one of us is a patient. So just those types of things is important to be mindful of during this process. So I just want to be mindful of time. I want to leave some time for a little bit of a break before the 6 o'clock. I believe it's going to be Dr. Gajar, I believe. I hope I pronounced that correctly. Again, you can chastise me later. But Dr. Dryman, thank you so much for your time. Do you have any last words for the people here?
Again, I whatever I'm bringing to the table, I hope it is helpful in this sense. I am new as a transgender individual, and I am not an expert by any means in providing advice or assistance. However, that being said, I hope that my message that I got across as I'm talking to you all is that never be afraid to be yourself, stand up for yourself, ask for help, be an ally to those around you. And if there's ever anyone that, for example, is interested in a surgical field and they need someone to reach out to talk about their future, talk about what's going on right now, they have questions or whatever, I'm always happy to be that point of contact. Dr. Mayerson can provide all of that information for you guys. She knows me very well. She has my contacts. If any of you feel that I, as an individual, would be beneficial in any way in your life, please feel free to reach out to me. And thank you for having me.
Thank you again so much for sharing your journey with us. I think we can all learn just from different people that are different from us, learning how to, treat those like that, both in the medical field, but personally as well. So again, thank you so much for taking your time. I also don't want to highlight that you did work 80 hours this week, so please go and get some rest. We need our surgeons because I don't want anything to do with the OR personally. So I know it's individualized, but again, thank you so much. I really do appreciate it. And we're all going to be taking a brief intermission and returning at 6 o'clock for our next speaker.